Hi, my name is Parminder. I'm going to describe to you my poster in 4.5 minutes. Brachytherapy can be used to treat a variety of cancers.
But the question is, what happens when there is another primary cancer immediately adjacent to where those brachytherapy seeds are? The first thing we have to do is figure out whether it's really a problem. Here's what we defined as being important criteria for determining whether it's a problem. Here's a case example of a patient who has prostate seed implants, who also requires surgery in the colorectal volume. You can see the whole bunch of seeds in the prostate area here. The volume to be removed is roughly in this area here. The rectal volume to be removed here is shown in yellow. Here's some images again showing where the prostate volume is and the colorectal volume to be removed. Here's a 3D view of that. The first step to dealing with this problem is to determine what the occupational exposures could be from this procedure. We can use the post-operative CT scan from the prostate brachytherapy to determine what the radiation distribution would look like close to the prostate region. Here are some estimates of doses that we might expect from this procedure. The important thing to note here is that if the surgeon operates without lead gloves, there is a fairly substantial dose delivered to the hands, well above the public limit. We had to develop an educational and operational plan. The surgical procedure is very similar to the brachytherapy procedure itself. Here's a few of the things that we brought into the operating room: lead gloves, detectors, survey meters, rings, and a jam kit that we used in standard brachytherapy. Here's the surgeon operating away. He refused to wear TLD rings because he felt that they affected his manual dexterity. Here's the surgeon's assistant. These two people had the highest risk in this procedure. Here's the colorectal volume that was removed, with the ink staining to show where the tumor volume was. Approximately this area here was the closest to the prostate region. This was scanned to ensure that there were no seeds in that volume before it was taken away to pathology. Here's a record of the doses that were measured from our survey meters at various instances and for a variety of individuals. The surgeon's assistant received the highest amount of dose, and this is in microsieverts. The procedure itself was about 2.5 hours long. After the surgery was completed, we had to determine if there are any other risks. The simplest way to determine whether seeds were dislodged or moved is to compare the post-operative brachytherapy CT scan with another CT scan obtained immediately after the colorectal surgery, and ensure that the number of seeds are the same and that the location of the seeds haven't been perturbed. There's a variety of learning points that we have from this experience, but most importantly, it's how to deal with this situation in the future. You can get more details on this poster at these websites. Thank you for your attention.